So, imagine a female powerlifter, right? Like she can deadlift maybe 400 pounds and just not even break a sweat.
Oh yeah, flawless form. The crowd is just absolutely roaring for her.
Exactly. And, from the outside, she looks totally invulnerable. But under the hood, she's actually secretly terrified to even sneeze.
Right, or like to celebrate too hard,
Mm.
because she knows her pelvic floor is on the verge of just completely failing her.
It's wild. And well, that is exactly what we are getting into today. Welcome to the deep dive, where we're looking at a medical paradox that kind of shatters our whole perception of what it means to be fit.
It really does. It's a fascinating topic.
Yeah, and we have this really incredible stack of clinical reviews, sports biomechanics research, and physical therapy case studies today. And we are using all of it to answer a very specific question for you.
Right, a question that honestly nobody really talks about.
Exactly. We're asking, can long-term, high-impact athletic training actually cause an overdeveloped pelvic floor that severely restricts what medical professionals call introital compliance?
Which is a very fancy way of saying something pretty alarming.
Yeah, basically, in plain terms, can being too strong make the vaginal tissue so rigid that they are literally unable to relax?
And, the statistics buried in these clinical reviews, they reveal a really isolating reality for these athletes. I mean, we're looking at data showing that 40% of all female athletes experience some form of pelvic floor dysfunction.
40%. That's almost half.
Yeah, it is. But then when you filter that data for elite female athletes, so like the gymnasts, the marathoners, the CrossFitters, that number spikes to an astonishing 80%.
80%. Wow.
Right. But because of this profound taboo surrounding pelvic health, the vast majority of them just suffer in complete silence.
Which is heartbreaking, really.
It is. Coaches usually don't know the signs, and the athletes themselves, well, they often assume it's just, the price they have to pay for greatness. Like, it's just normal.
So our goal today is to pull the pelvic floor out of the shadows. We have to stop viewing it as this passive hammock of tissue just sitting quietly in the pelvis.
Absolutely. We need to start analyzing it as a highly active, totally crucial gear in the athlete's entire kinetic chain.
Right. So to understand how a muscle gets so overdeveloped that it restricts normal function, I think we first need to map out what it's actually doing during a grueling workout.
Yeah, that biomechanics piece is key.
Because I feel like the cultural assumption is that the pelvic floor is just, the emergency brake that stops you from peeing your pants in public.
Right, like that's his only job.
Yeah. But looking at the biomechanics data you brought, this muscle group is actually acting as a primary structural stabilizer for the entire human body.
It really is. The primary mechanism at play here during any high-impact sport is the generation of intra-abdominal pressure, or IAP.
Okay.
Yeah. So whether an athlete is, say, loading up a heavy barbell, or exploding upward for a rebound in basketball, or even just striking the pavement during a sprint, the body has to instantly stiffen the spine.
Because if you're like a wet noodle, you can't lift anything.
Exactly. Without a rigid trunk, your arms and legs literally cannot generate power or transfer force. So to create that rigidity, the body essentially inflates the abdominal cavity with pressure.
And the physical therapy sources have this brilliant analogy for this IAP mechanism that I just love. They call it the pressurized soda can.
Oh, that's such a good way to visualize it.
Right. So your diaphragm acts as the top of the can. It pushes down when you inhale and brace for a lift.
And then your abdominal muscles are like the rigid aluminum sides of the can, just holding everything in tight.
Exactly. Which leaves the pelvic floor acting as the bottom of the can. And I mean, if you shake up a soda can, the pressure inside is immense.
Oh, yeah, it wants to burst.
Right. So to keep the bottom from simply blowing out under all that strain, those pelvic floor muscles have to brace back upward with incredible force.
And you have to consider the actual physical load that's happening during a typical training session, too. The biomechanical data shows that runners, for example, are absorbing 2 to 3 times their own body weight with every single foot strike.
Wait, really? Every single step?
Every single step. And they are doing that for thousands of steps over miles of road.
That is just a staggering amount of force.
It really is. So the pelvic floor is forced to fire back up against that massive repetitive downward force, step after step, just to maintain the seal and support all the internal organs.
Which brings us to the medical debate outlined in our sources because that repetitive strain leads directly into this. Historically, the medical community seemed to have a very specific bias about female pelvic health.
Yeah, mostly stemming from postpartum studies, actually.
Right. They just assumed that any dysfunction was caused by weakness, like things were just too loose. And there's a researcher, Kari Bow, who outlines this beautifully in her work.
She's fantastic. Her research really broke new ground.
Yeah, she details these two competing hypotheses for what happens to the pelvic floor of an elite athlete. And the first hypothesis basically aligns with that old traditional thinking.
Right, the idea that the muscles simply get overstretched and overloaded by all those repetitive, high-intensity impacts.
Which, to be fair, makes intuitive sense. You know, you stretch a rubber band far enough, and frequently enough, it loses its elasticity, micro tears develop, and the whole structure weakens.
Exactly. For a long time, doctors just assumed female athletes were wearing out their pelvic floors prematurely, like they were just aging the tissue faster.
But then Kari Bow's second hypothesis completely flips the script.
It really does. It changes everything about how we treat this.
Because this second model suggests that in response to extreme athletic training, the pelvic floor muscles actually respond just like your quads or your biceps.
Right. They experience hypertrophy,
Yeah, they become dramatically stronger, thicker, and bulkier.
which, on the surface sounds like the ultimate goal for an athlete. A thicker, stronger muscle provides fantastic rigid support.
I mean, yeah, it's the reason a gymnast can absorb the G-force of a dismount without her internal organs dropping out.
Exactly. But the research points out a massive catch here, that increased bulk and strength severely complicates any physiological activity that requires those muscles to stretch, yield, and lengthen.
Because strength doesn't always equal coordination.
Yeah, exactly. Strength rarely equals coordination. And this introduces the clinical concept of a hypertonic pelvic floor.
Hypertonic, so meaning like high tone.
Yes. But hypertonicity doesn't just mean a muscle is, tight in the way your hamstrings might feel tight after a long run. It indicates a state where the muscles are locked in a constant, unyielding spasm.
Oh, wow, so they just can't let go.
Right. The resting baseline of the tissue has fundamentally changed. The muscles have literally lost the neurological and mechanical ability to drop, open, and relax.
So going back to our soda can analogy, it's as if the muscles at the bottom of the can are bracing so hard for so many hours a day that the nervous system basically forgets how to turn off the bracing reflex.
Yeah, even when the can is open and the athlete is just, resting on the couch watching TV.
That sounds miserable. And the cellular environment inside a hypertonic muscle, according to the sources, is actually quite hostile.
It is deeply hostile. The sources detail this very specific, really grim physiological cascade.
Walk us through that. What's actually happening at the cellular level?
Well, when a muscle remains in a constant state of contraction, the physical density of the tissue actually squeezes the surrounding capillary shut.
Oh, so it cuts off its own blood supply.
Exactly. It restricts fresh blood circulation, which creates a localized condition called ischemia.
Right, so the muscle is essentially suffocating. Because the blood flow is cut off, there isn't enough fresh oxygen getting in, and crucially, the cellular waste products can't get flushed out.
Yeah, it's a one-way street with no exit.
The sports science literature mentions a huge buildup of acidic metabolites, like lactic acid, just pooling in the tissue.
And that pooling of acidic waste creates a highly toxic local environment. This acidity irritates these chemical sensors we have called nociceptors, which then start firing off localized pain signals.
So it's literally burning from the inside out.
Pretty much. Over time, this chronic ischemia and chemical irritation lead to the formation of myofascial trigger points, or MTRPs.
And those are like the knots you feel when you get a deep tissue massage.
Yeah, exactly. There are these highly hypersensitive nodular knots within the muscle belly itself, and they just radiate pain and further restrict the muscle's ability to stretch.
Okay, but I have to challenge something here because looking at the symptom lists for these athletes, the puzzle pieces seem kind of contradictory.
How so?
Well, one of the most prevalent complaints among athletes with hypertonic pelvic floors is stress urinary incontinence. You know, leaking urine when they jump, laugh, or sneeze.
Right, which is incredibly common.
But if this muscle is incredibly hypertrophic, like thick, and locked in a constant rigid spasm, leaking makes no sense to me. I mean, a vault door that is rusted shut shouldn't let anything slip through, right?
You are not the only one confused by that. That paradox stumps a lot of general practitioners, too. But the key to unraveling it lies in understanding the difference between baseline tension and reflexive timing.
Okay, baseline tension versus reflexive timing. Break that down for me.
So the muscle isn't failing because it's weak. It's failing because it's already maxed out. If your baseline tension is already at 100% just to keep those trigger points locked up, there's literally no room left for a sudden reflexive contraction when a spike in pressure happens.
Oh, like it has nowhere else to go.
Exactly. Picture an athlete trying to execute a maximum height vertical jump, but they have to keep their knees completely locked straight.
Yeah, you can't do it. You cannot generate upward propulsion without first dipping down.
Right. The pelvic floor operates on a very similar principle of excursion. To effectively clamp down and seal the urethra against a sudden spike in intra-abdominal pressure, like a sneeze or a heavy box jump, the muscle actually needs a split second of agility to contract further.
But because it's hypertonic, it's totally rigid, it can't react in time.
Exactly. The pressure wave of the sneeze just overpowers the stiff muscle, and you get a leak. It is entirely a failure of coordination and timing rather than any lack of strength.
That reframes the entire issue for me. The muscle is just an inflexible brick wall. And, that rigid tension brings us to honestly the most guarded, taboo aspect of this whole deep dive.
Yeah, this is the part people really don't talk about.
Because this constant state of protective spasm creates a severe physical barrier that completely restricts introital compliance, which just devastates an athlete's sexual health.
It does. And to clarify for the listener, introital compliance refers to the viscoelastic properties of the vaginal opening and the surrounding tissues. Basically, their ability to yield, soften, and comfortably stretch to accommodate pressure.
Right. And when an athlete with a hypertonic pelvic floor attempts to, say, use a tampon or undergo a routine gynecological exam or engage in penetrative sex, they aren't just dealing with like mild discomfort.
No, not at all. They are pressing directly against a wall of hypertrophic muscle tissue that is locked in a defensive spasm and peppered with those highly sensitive myofascial trigger points we talked about.
The tissues simply lack the compliance to yield. And the clinical descriptions of how this manifests are just brutal. Athletes frequently report this sharp stabbing or like burning sensation the moment penetration is attempted.
Yeah, it's an immediate, intense pain response.
And others experience deep dyspareunia, which is this profound aching pain with deeper penetration caused by hitting those ischemic knots deeper in the pelvic bowl.
Which is terrifying if you don't know what's happening.
Truly. And I was particularly struck by a specific detail from the physical therapy case studies. Female runners often describe this deep internal pelvic ache after a long marathon that feels identical to severe menstrual cramps, even when they aren't menstruating.
Yeah, that faux cramping sensation is basically the hallmark of the pelvic floor muscles just crying out from the ischemia and the fatigue of absorbing thousands of foot strikes.
It's just so much trauma to that one area.
It is. And furthermore, the clinical data highlights a really critical nuance regarding sexual dysfunction here that often leads to misdiagnosis, which is the phenomenon of delayed pain.
Right, the delayed pain. The sources mention that a lot of women dismiss the pelvic floor as the culprit because they don't necessarily feel agonizing pain during intercourse.
Yes.
The severe pain hits them like hours later or even the next morning, which leads them to think something else entirely is wrong, like an infection or something.
Exactly. And the physiology behind that is fascinating. During arousal, the body is flooded with endorphins and blood flow, which can sometimes override that baseline tension just enough to allow for compliance and penetration.
Okay, so the body kind of masks the issue temporarily.
Right. But the physical activity itself forces those already exhausted ischemic muscles to work even harder. And this triggers a cascade of microspasms.
So the delayed pain is basically the delayed physiological fallout.
Precisely. The muscles struggle to return to their normal resting tone after the event, and that triggers a massive inflammatory and nociceptive response hours later.
One of the physical therapists in the sources used an analogy that perfectly encapsulates this delayed response, I thought.
Oh, the steering wheel one.
Yes. Imagine driving a car for 6 hours on this treacherous, icy road. You have this white-knuckled death grip on the steering wheel the entire time.
Yeah, just totally tensed up.
But while you are driving, the adrenaline and focus keep you in the zone. You don't even realize how hard you are clenching. But the moment you finally arrive, park the car, and try to peel your fingers off the wheel, this burning, aching exhaustion just radiates through your hands and forearm.
It's perfect because you didn't injure your hands in an accident, right? You simply overworked them to the point of ischemia by refusing to let go. And that is the exact mechanism driving the delayed pelvic pain.
Yeah.
The muscles have been clenching so hard against the physical load of the sport and the mechanical friction of intercourse that trying to finally relax triggers a severe pain response.
And, knowing how elite athletes are psychologically wired, the moment they realize a muscle group isn't performing correctly, their default instinct is to attack the problem with more training.
Oh, always. More reps, more weight.
They assume they need to work harder to fix the leak or push through the pain.
And that instinct plunges them straight into what sports therapists call the Kegel trap, which is arguably the absolute most counterproductive thing they could possibly do.
Yeah, because the cultural reflex for any female pelvic issue, whether it's incontinence or pain, is to blindly prescribe Kegel exercises.
You just do your Kegels.
Exactly. But prescribing hundreds of Kegels to a hypertonic athlete is like telling someone to do heavy bicep curls with an arm that is already locked in a massive, agonizing cramp.
It's madness. Forcing a muscle that is already suffering from ischemia and trigger points to execute further intense contractions will only exacerbate the spasms. It just increases the resting tension.
You absolutely cannot strengthen a muscle that is trapped in a hypertonic state.
No.
Yeah.
The rehabilitation protocol requires a complete paradigm shift. The athlete has to learn how to restore the muscle's normal resting length before any functional training can occur.
And the sources refer to this rehabilitation process as down training. It's not about building more capacity. It's about teaching the nervous system and the local tissue how to finally yield.
Yes. Down training focuses heavily on mechanical relaxation and neuromuscular re-education. And interestingly, the foundational pillar of this therapy is actually diaphragmatic breathing.
Which ties perfectly back into our soda can analogy from earlier.
Exactly.
If the diaphragm and the pelvic floor operate like a synchronized piston, then how an athlete breathes directly dictates the tension in the pelvis. And the data notes that chronically stressed, high-performing athletes are notoriously shallow chest breathers.
They are. Their diaphragms barely move, which keeps their pelvic floors perpetually sucked up into this tightened defensive posture.
So by retraining the athlete to take deep, true belly breaths, the diaphragm physically drops downward, pushing the viscera down and mechanically forcing the pelvic floor to stretch, lengthen, and drop with it.
Breathing properly is an incredibly potent mechanical intervention. And alongside breathwork, specialized physical therapists also utilize manual therapy.
Right, getting in there physically.
Yeah, this involves internal, hands-on, very gentle release of those myofascial trigger points to physically restore blood flow and break up the ischemic knots.
They also have to modify how the athlete trains in their specific sport, right? Specifically how they manage that intra-abdominal pressure we talked about.
Yes, that's crucial. Instead of holding their breath and bearing down onto their pelvic floor during the exertion phase of a heavy squat, they are taught to forcefully exhale.
Ah, so that gives the internal pressure a release valve out through the mouth, rather than shoving the entire kinetic load down into the pelvis.
Exactly, it dissipates the force.
But the literature also covers severe refractory cases where the tension is so deeply ingrained that breathing and manual therapies simply aren't enough to break the spasm.
Right, because when an athlete has been chronically clenching for years, maybe decades, the neural pathways firing those contraction signals become incredibly stubborn.
They just won't turn off.
No. So for these advanced cases, clinical trials have shown remarkable success using Botox injections directly into the hypertonic pelvic floor muscles.
Wait, the exact same neurotoxin used in cosmetic dermatology? Like for wrinkles?
Precisely the same stuff. Botulinum toxin works by blocking the release of acetylcholine at the neuromuscular junction, so it temporarily paralyzes the target muscle fibers, completely halting the electrogenic signals that cause the spasms.
That is wild.
It is, but the clinical data shows that targeted Botox injection can dramatically drop pain scores and reduce resting muscle tension by up to 25% within just a few weeks.
Wow. But I assume it doesn't cure the underlying movement dysfunction, right?
No, it doesn't. But it hits the neurological reset button. It forces the muscle to finally unclench, eliminating the ischemia long enough for the down training and physical therapy to actually take effect.
That makes so much sense. Well, we have journeyed deep into the biomechanics of a highly misunderstood epidemic today.
We really have.
We started by examining how high-impact sports, the heavy lifts, the marathon miles, the gymnastic landings, demand immense intra-abdominal pressure to stabilize the kinetic chain. And to counteract that downward force, the pelvic floor overdevelops.
Right.
But rather than just gaining functional strength, Kari Bo's hypertrophy model shows us how these muscles get stuck in a hypertonic locked state. That relentless clenching chokes off local blood flow, initiating a toxic cascade of ischemia and myofascial trigger points.
which leads to so much downstream dysfunction.
Exactly. The result is a rigid, inflexible muscle that cannot react to sudden pressure, causing paradoxical urinary leakage. And even more devastatingly, this rigid wall of tissue severely restricts introital compliance, turning basic tissue yielding into a source of excruciating, often delayed, sexual pain.
Yeah.
And the solution isn't the traditional advice of pushing harder or doing more Kegels. It requires breaking the cycle of ischemia through downtraining, manual therapy, breath work, and sometimes even medical intervention like Botox, just to teach the body how to finally let go.
And, the necessity of letting go brings up a fascinating secondary layer to this entire clinical picture that I want to leave you with.
Oh, I love this part.
Because the pelvic floor is not just a mechanical gear, right?
Right.
It is deeply intertwined with the autonomic nervous system. It is highly reactive to emotional and psychological stimuli.
So it responds to stress.
Absolutely. Consider the primal response of a frightened animal. It instinctively tucks its tail between its legs. That action is driven by the pelvic floor muscles contracting in a deeply embedded subconscious fight-or-flight stress response.
Which means the human pelvic floor is physically bracing against danger, whether that danger is a 400-pound barbell or extreme psychological stress.
Exactly. So as you digest everything we've uncovered today about biomechanics, ischemia, and hypertonicity, consider the mindset of the elite athletes we've been discussing. You don't reach the absolute pinnacle of human performance without enduring relentless performance anxiety, immense psychological pressure, and a constant high-stakes demand to succeed.
You just can't. The mental toll is huge.
So I leave you with this to ponder. When we look at an athlete suffering from a locked hypertonic pelvic floor, how much of that restricted compliance is purely the mechanical result of thousands of heavy foot strikes?
No.
And how much is actually the physical manifestation of their psychological burden? Is it possible that for these high performers, the pelvic floor has simply become a subconscious barometer for their hidden, unyielding stress?